will always remain normal, right? There is a problem or something happens inside the cell only when some problem happens. What could be the problems that happens to this particular cell? Can you tell me what could be the problems that can happen in this particular cell?
Physiological and pathological process now.
Okay, yeah, physiological and pathological. What could be the injuries that can happen?
Trauma.
Trauma, agreed.
Trauma, inflammation, infection.
Trauma, infection. Okay. Inflammation is a response to that cell injury. The inflammation is not as such the cell injury. There is some infection or something that caused that inflammation to happen. Okay. So very simple. Whenever there is a reduced ATP to the particular cell, that time there will be problem. When there is some mitochondrial damage, and there is no calcium that is entering inside, when the reactive oxygen species that is increased, when there is a membranous damage because of some infection or something, or when there is a protein misfolding or a DNA damage because of some mutation, all these things will cause something called as the cell injury. This cell injury, it can be of multiple types. Okay. So the one possible cell injury which we know commonly is two things. One is hypoxia, the other one is ischemia. What do these two things mean?
Hypoxia means oxygen level coming, pressure level.
Reduced oxygen supply to the tissue. What is ischemia then? Ischemia is reduced blood supply to the tissue. Okay. I can say whenever there is an ischemia, that will result in hypoxia, that will then result in cell injury. Right? This is the way how a cell injury will progress. Then, if the cell is going to get injured, there are different level of injury. What are the different levels of injury? It can either be a reversible injury where there is only a mild transient problem that has happened. So reversible injury means whatever the stimulus, if the stimulus is taken out or the stimulus is solved, it will get back to the normal cell. But if the stimulus is keeps on comes inside, the cell will go for adaptation. Okay. A part of the adaptation will be reversible, but if it goes very severe and progressive, it becomes an irreversible injury. Right? So we have to know about the reversible and irreversible injuries differentiation. First thing, in a reversible injury, there will be cell swelling. Whereas in a irreversible injury, there will be lysosomal swelling. Here, there will be formation of blebs. And myelin figure formations will be there. Whereas here, mostly the mitochondria, the cells will bleb here. Whereas in irreversible injury, the mitochondria will go for a massive swelling, leakage, and the amorphous densities will be formed in the mitochondria. Third thing, in a reversible injury, there will be decreased ATP and there will be a decreased pH. Acidic environment will be there for the cell. In case of an irreversible injury, here the problem is all the damage has happened. DNA damage has happened. endoplasmic reticulum has disrupted. And the plasma membrane has also got disrupted. This is only a minor injury like swelling, so that it is reversible. Whereas these are all big damages, it just cannot be reversed back. Can you tell me the example of an irreversible cell injury? Both, tell me both. In case of a reversible, the cell can go for an adaptation. Cellular adaptation can happen to a level. Beyond a level, the cellular adaptation will become irreversible. So cellular adaptation, severe form, plus other types of injury. First, tell me what are the different cellular adaptations that you know of?
Hypertrophy, hyperplasia.
Yes. Hypertrophy, hyperplasia, atrophy. All these things are cellular adaptations. What is a simple atrophy? Simple atrophy is a reduction in only a structural components of the cell. There is a numeric atrophy. There is a reduction in the number of cells. What is hyperplasia? Hyperplasia is the increase in the number of cells. What is hypertrophy? Hypertrophy is increase in the size of cell. Okay, these are the cellular adaptations maybe we knew of. What are the irreversible cell injuries that you know of? What are the irreversible cell injuries?
Apoptosis and necrosis.
Exactly. Irreversible is apoptosis and necrosis. Okay. See, in case of a reversible injury, things can get back to normal. But in case of an irreversible injury, there will be loss of phospholipids, cytoskeleton is lost, free radicals are increased, lipid breakdown happens. All these things lead to a increase in calcium influx, thereby leading to the further breakdown of the proteins inside the nucleus, thereby degrading the cell. So, in the reversible injury, I told you, right, there will be blood formation. See, look at this. This is the blood formation that is happening. So, once the blood formation happens, they try to recover back to normal and get back to normal. If not, they'll end up ending inside the irreversible injury, where the nuclear components are also degraded and thereby causing necrosis of the particular tissue. If you see difference between apoptosis and necrosis, which is a process which is not harmful to the body. If I take necrosis and apoptosis, which process is not harmful to the body?
Apoptosis.
Exactly. Why is it not harmful to the body?
Necrosis, the content will be out.
Okay.
In necrosis, the content will be dead, cells will dead for permanently.
Okay. Even in apoptosis, the cell will die permanently.
Apoptosis does not cause inflammation of the nearby cells.
Exactly. That is the content. There will be no inflammation in apoptosis. There will be no inflammation. Whereas here, there will be a severe inflammation that happens because of the necrosis. Since there is no inflammation, it is a very smooth way of destructing the cells that are not important for the body. So hence it is called as a programmed cell death. Hence it is called as the programmed cell death, where the cell dies. How does the apoptosis produce? Usually there will be cell shrinkage that happens. And after shrinkage, there will be fragmentation, thereby apoptotic bodies will be formed. Small, all the cell contents will be getting to big, small fragments. And after that, the phagocytes will go engulf those fragments. And by using the phagocytosis, that is the lysosome will go and attach to the content and thereby cause the digestion of that particular cell. This is how a apoptosis happens. Whereas in case of a necrosis, you have a cell inflammation, swelling of cell will be present. The cells will swell, and after swelling, the swell will break down of this plasma membrane will there, thereby releasing all the contents of the cell randomly out inside the circulation. So when all the contents inside the cell is randomly out inside the circulation, there will be that will be considered as as something abnormal by our body, and inflammation will be triggered by our body. So if you say the difference between necrosis and apoptosis, to summarize, first, the size of the cell, swelling will be there, shrinking will be there. Here, many cells will be affected. Like one cell is necrosed, means surrounding cells will also be affected. But if one cell goes for apoptosis, only one cell will be affected. So then regarding the inflammation will be present in necrosis. It will not be present in apoptosis. In the cell membrane will lysis. Here, the membrane will be intact and the integrity will be maintained, and still the apoptotic body will be formed. Here, there will be random degeneration of DNA. Whereas in apoptosis, the process of damage will be non-random degeneration, along with the chromatin condensation. Okay, so what are the different types of chromatic condensation that you know of? Am I audible?
Yes, ma'am.
Tell me, what are the different types of chromatin condensation that you know of?
Glycosis, karyolysis, karyolysis.
Yes, karyolysis, karyorexis, right? Okay. What does karyolysis mean? What does karyolysis mean? Karyolysis means simple, as the name suggests, the karyolysis is the nuclear chromatin is usually digested by the nuclease enzyme. It is digested by the nuclease enzyme. Whereas what is karyorexis? Karyorexis is the rupture of nuclear membrane. Rupture of nuclear membrane. What is pycnosis? Pycnosis is a shrinkage of nuclear cell, or the shrinkage of the nucleus. So these are the different chromatin condensation that happens inside the body in case of apoptosis. So this is the difference between apoptosis and necrosis. If you ask me the necrosis, what are the different types of necrosis that we know of? Can you tell me the different types of necrosis?
Coagulative, liquefied, caseous, fat, fibrinoid, gangrene.
Okay, super. Liquefactive necrosis, in which area of the body is it mainly seen?
Brain.
It is mainly seen in the brain. Okay, that is very important. And one main thing with liquefactive necrosis that we have to know is it is a lysosomal degeneration. Like the lysosomal enzymes will cause the decomposition of the cell by autolysis. And the cellular integrity, the cellular structures, the cell wall will not be maintained here. Hence, even in a histopathological examination, if you ask for a liquefactive necrosis, you will not see the pattern of that particular necrosis. If it's a brain tissue, you will not be even be able to identify that it is a brain tissue. So the normal pattern of the cell will be destroyed in liquefactive necrosis. In which type of necrosis the cellular structure will be maintained, but still the cell will die? What is that type of necrosis?
Coagulative.
Exactly, that is the coagulative necrosis. This is the most common type of necrosis. It is mostly an hypoxic cell death of the solid organs. Solid organs like the kidney, heart, adrenal. Okay. Then what is the necrosis that involves the pancreatic lipase? When the pancreatic lipase is activated, it happens in acute pancreatitis, right? So this acute pancreatitis, you see fat necrosis. There are two types of fat necrosis. One is enzymatic and other one is non-enzymatic. Enzymatic example is this acute pancreatitis. Fat necrosis, non-enzymatic. Examples, it happens in the breast, then subcutaneous tissues, and in the abdominal fat. All these things is the non-enzymatic fat degradation. What is the type of necrosis that is seen in granulomatous inflammations or in case of a disease with forming granulomas? First, tell me the disease. It's caseous necrosis.
No.
I agree, it's a caseous necrosis. Caseous necrosis is seen in which area?
Liver,
Lungs.
First of all, you tell me the disease and then tell me the
TB.
area.
TB. TB.
Okay. Agreed, TB then. Any granulomatous diseases? Histoplasmosis?
Sarcoidosis.
Histoplasmosis. Then sarcoidosis, agreed, sarcoidosis. Syphilis. Coccidiomycosis. These are the areas where you see the caseous necrosis. Caseous necrosis will be usually white in color. Okay. And then, how about the fibrinoid necrosis? Where do you see this fibrinoid necrosis? It is mostly seen in
Blood vessels.
Sorry?
Blood vessels.
Exactly, it's seen in the blood vessels, especially in the vasculitis. Example, PAN, polyarteritis nodosa, then SLE, systemic lupus erythematosus, rheumatic fever. Then you have this malignant hypertension also. You can see this fibrinoid necrosis happening. In malignant hypertension, there will be hypertrophy of the intima of the blood vessels, thereby causing a signet ring, like onion ring appearance. If it goes for a long time, if it presents for a long time, then that will in turn lead to the necrosis. Usually in the fibrinoid necrosis, if you see this area, the inside part will be dead. That's why there will be this shadow, the pink color one, and after that, you know the hematoxylin eosin stain, right? Hematoxylin stain will be there in the center, and then eosin stain will be there for the nucleus around the area because of the inflammation. Okay, any other types of necrosis that we have missed?
Gangrene.
I think, yeah, gangrene. Yeah, exactly. Gangrene. What are the different types of gangrene that you know of?
Dry gangrene, wet gangrene.
Okay, dry gangrene, wet gangrene. Where do you see dry gangrene? Where do you see wet gangrene? What is the type of necrosis that is seen here?
Diabetes mellitus.
Okay, diabetes, okay, I agree. Necrosis can happen because of any reason, even a block of the vessel. A peripheral arterial disease can also cause this gangrene. Any blood supply that is affected to that particular area, if the leg is there, means blood supply is affected, means that will lead to dry and wet gangrene. Gangrene, I agree. What is the type of necrosis that's seen in dry and wet gangrene?
Dry coagulator, wet liquid factor.
Yes, dry is coagulator and wet is liquefactive. This is the necrosis. Okay, then I'll tell you a few inflammatory mediators. You tell me what are the contents. I mean, what will be the presentation if that inflammatory mediator is increased? If interleukin 1 is elevated, what is the clinical presentation? If the interleukin 1 is elevated in the body, what will be the clinical presentation in that patient?
Fever.
Exactly, fever. If bradykinin or nitric oxide is elevated,
Dilation.
dilation will cause hypotension, right? How about C complement C3A and C5A? C3A and C5A? Simple inflammation will be there for the patient. How about Hageman factor? When the Hageman factor is elevated, the patient is going for DIC, disseminated intravascular coagulation. These are the inflammatory mediators that will come up with the at the end result of necrosis. And also, in case of apoptosis, there are few genes or few genes which promote apoptosis and few genes which inhibit apoptosis. What are the genes that promote apoptosis? Apoptosis promoters. P53, agreed. Then BAX, BIM, BAC. How about inhibitors?
BCL2, MCL1.
Exactly. BCL2, BCLXL. I think MCL will also come here in case of apoptosis inhibitors. Okay. So this will be the necrosis and apoptosis. The another topic in this chapter would be calcification. Before that, we spoke about hypoxia, right? Different types of hypoxia. Hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and history of it. What is hypoxic hypoxia? Whenever there is a problem with the lungs, there will be reduced oxygen to the body. There, the hypoxic hypoxia happens. In anemic hypoxia, there will be reduced hemoglobin or the reduced RBCs. The oxygen carrying capacity of the blood will be less and hence leading to anemic hypoxia. What is stagnant hypoxia? Stagnant hypoxia is because there is a problem with the circulation. The carbon dioxide which is produced by the cells is not able to be come out. They are not able to come out. That is one thing. Second thing, there is a problem with the cardiac pumping. Cardiac pumping problem means there will be a problem with the tissue perfusion. There will be a reduced tissue perfusion. That injury will be called as stagnant hypoxia. Histotoxic hypoxia, example. Histotoxic hypoxia, example. Exactly, cyanide poisoning. Here, oxygen is present, blood is going normally, everything is normal. But the problem is the cyanides are attached to the hemoglobin, thereby They are not allowing the oxygen from the hemoglobin to be delivered to the tissue. The oxygen is there in the cell, but it is not able to be utilized by the cell. Example is cyanide poisoning, then diphtheria toxins, and sodium nitroprusside poisoning. Also present in this histotoxic hypoxia pattern. Then coming to the last topic of this chapter is the calcification. What are the different types of calcification that you know of? What are the different types of calcification that you know of?
Dystrophic and metastatic.
Yes, dystrophic calcification and metastatic calcification. Difference between them?
Depends the calcium levels.
Usually, first thing, in dystrophic means, remember, disease. The calcium will get deposited in the diseased area of the body, not in the normal tissue. Here, the calcium will get deposited in the normal tissues. Okay. Second, here there will be normal calcium levels. Whereas in metastatic hypercalcemia, there will be increased calcium levels, serum calcium levels in the bodies. Examples of dystrophic calcification is the cardiac cause, erythromatous plug that is present in the vessels. Then calcification in the heart valves. Then tuberous calcifications. Then aneurysm. All these things will cause dystrophic calcification. In case of metastatic calcification, you have hyperparathyroidism, where there will be an increased calcium in the body. The parathormone will convert the calcium which is there inside in the bones to get inside the circulation, causing hypercalcemia. Multiple myeloma because of increased turnover of the cells. Paget's disease. Sarcoidosis. And vitamin D intoxication. Okay, these are the dystrophic and the metastatic calcification difference. If you ask me, the other MCQ that can be asked here, what is the most common organ affected in calcification? It is the lungs. Which is the most common organelle affected in calcification? It is the mitochondria. Okay, so this is what is regarding the basics. Okay, just give me 5. So, is my screen visible now?
Yes, ma'am.
Okay, good. So, necrosis has happened, and now something is wrong with the body, and so the body has to react to it. How will it react? It will react by giving inflammatory mediators, thereby causing the inflammation as such. What will be the first, whenever some problem happens in the body, first thing will be acutely, there will be an inflammation that happens that try to sort out the problem. And if this acute inflammation is not sorted out, still if the causative etiology is still continuing, then you will have to, then it will go for a chronic inflammation. Right? So, in case of an acute inflammation, what is the characteristic of an acute inflammation? If you say acute inflammation, what should come to your mind? What should come to your mind if I say that? This is a normal tissue and this is an inflamed tissue, especially in acute inflammation. Look at the blood vessels. It has got increased. Vasodilation is there. Second thing, look at the blood cells, the lymphocytes and macrophages. The numbers has increased. From the blood vessel, it is coming out. So there is an increased vascular permeability. In case of an acute inflammation, the hallmark will be increased vascular permeability. This is the main thing that happens in acute inflammation. How about in a chronic inflammation? What is the problem with a chronic inflammation? What is the problem with a chronic inflammation? In acute inflammation, vascular changes, the neutrophils will come out, mediated this called, and try to solve the problem. Then if it progresses, it becomes a chronic inflammation. In chronic inflammation, you have continuous angiogenesis, new vessels forming. They are trying to solve the problem by forming new vessels. Then recruiting more mononuclear cells to solve the problem. If there is too much of inflammation that happens, that inflammation is usually healed in the form of fibrosis. Whenever there is a fibrosis, look at the blood vessels here. It has lost the function comparing to the normal one. So the loss of function will be there because of the fibrosis. This is a way how a chronic inflammation can proceed. So I will say the hallmark of acute inflammation would be increased vascular permeability, whereas the hallmark of chronic inflammation would be tissue destruction. So this is the main things regarding inflammation. Then you have to know about the inflammatory mediators. The one such inflammatory mediators are the ones from the arachnoidic acid. You have cyclooxygenase releasing the prostaglandin G2. From G2, H2 is produced. Then prostacyclin G1 is produced, and thromboxane A2 is produced. If you see these two are produced from same prostaglandin H2, but they have different action. This causes vasodilation, whereas the thromboxane A2 causes vasoconstriction. Prostacyclin causes the platelet inhibits the platelet aggregation, whereas thromboxane A2 promotes the platelet aggregation. You can remember it as throm means platelet, box means putting it inside the box. That is promoting the platelet aggregation. You can remember it like that. So the difference between prostacyclin and thromboxane A2 is important that you have to know of. The other inflammatory mediators that comes are through the lipoxygenase enzyme. The derivatives would be the leukotrienes. The leukotriene, mostly they will cause vasoconstriction, bronchospasm, and increase vascular permeability. Rather than I will say it is an inflammatory mediators. There is something called chemotaxis. Chemotaxis means that helps in the inflammatory mediators to go and reach that particular spot where there is an inflammation or an infection. This is called chemotaxis. What are the important things that is needed for the chemotaxis to happen? First, bacterial products as needed. Then complements C5A is needed. Leukotriene B4 is needed, and interleukin 8. All these things are very important for the chemotaxis to happen. That is for the movement of the inflammatory cells to that particular area. There is something called as the respiratory burst enzyme. What is called as respiratory burst enzyme? That is involved in the destruction of the microorganisms that comes inside the body. Respiratory burst enzyme. It is NADPH oxidase. It is NADPH oxidase. Whenever there is a defect in NADPH oxidase, what will be the syndrome that is formed? Come on, tell me. These are questions you should know. Whenever there is a deficiency of this NADPH oxidase, what will happen? NADPH deficiency will lead to chronic granulomatous disease, CGD. CGD, chronic granulomatous disease. Okay, then in what else? That's all regarding the thing. If you speak about the prostaglandins, there are different prostaglandins that are formed inside the body. One such prostaglandin that is used for treatment is prostaglandin F2 alpha. The prostaglandin F2 alpha analogs. Name of the drugs, any idea? Carboprost and latanoprost. Carboprost, it is used in the treatment of PPH. It basically causes vasoconstriction. What is PPH?
Postpartum hemorrhage.
What is exactly? Latanoprost, it is used in the treatment of glaucoma. It reduces similarly vasoconstriction, and hence it decreases the intraocular pressure, thereby producing a symptomatic relief in glaucoma. Then coming to one important MCQ, what is the hallmark of inflammation? Hallmark means the 5 cardinal signs of inflammation. Rubor. What is rubor?
Redness.
What is rubor tumor? Yes, rubor is redness. Tumor?
Swelling.
Yes, swelling. Calor? Calor is heat. Dolor is pain.
Pain.
And the 5th one was recently added by Virchow. This was given by Celsus. And Virchow recently added recently in the sense in the last 1 century. The 5th sign of inflammation, that is loss of function. That is the loss of function. So this is the 5 cardinal signs of inflammation. Next, coming to the cells that are involved in the inflammation. Few chemicals are derived from the cell, and few chemicals are derived from the plasma protein derived. They come from the liver. If it's come the cell, the mediators would include the histamine and serotonin. These comes from the mast cells, basophils, and the platelets. Whereas all the leukocytes will give the other prostaglandins, leukotrienes, and all those things. Complement is basically from the liver. The Hegemon's factor is from the coagulation system, and that's why I told you whenever there is an increase in the Hegemon's factor, there is a chance of disseminated intravascular coagulation to happen. If you see the specific cells, I'll tell you the specific cell, you tell me what are the important things about this. Neutrophil. Neutrophil means what is the first point that you'll think? It is the first cell to come to the spot, right? First cell to come to injury spot will be neutrophils, and hence it is the primary cell that is involved in acute inflammation. It also has the capability of phagocytosis. Okay. Second thing, the monocytes. When they say monocytes or macrophages, when is it a monocyte and when it is a macrophage? When this is inside the blood, it is a monocyte. When it comes to the tissue, it becomes a macrophage. Okay, this will be the second cell to come to the spot. Second cell to come to the injured spot. It has the major phagocytic potential. It will try to sort out the problem by itself. In acute inflammation itself, it will also be involved. But despite of its involvement, the problem is still continued. Then along with the monocyte, there is someone else who comes and acts, that is the lymphocytes and the plasma cells. The plasma cells usually releases the immunoglobulins, and hence they come to action. And when these two, they are there along with the monocytes to fight the particular process, it becomes an inflammation, chronic inflammation. Then how about eosinophils? Whenever a eosinophil is increased, what all will you think of? Whenever an eosinophils are increased, what will you think of?
Allergy.
Cool.
Exactly. Allergy. Then what else? Allergy is a common thing. You are like, a layman can say allergy. That is agreed. What is the other one? Very important one. Parasitic infections. Whenever there is a parasitic infection in the body, there is a high chances of increase in the eosinophils. How about mast cells? Mast cells usually release the histamine, which is involved as a chemical mediator for both acute and chronic inflammation. For both acute and chronic inflammation. Okay, this is about regarding the cells. I already told you, monocytes, when it goes to the tissue, it becomes a macrophage, right? If a monocyte goes to the brain, what will become? What macrophage will it become? What is the name of the macrophage that is present in the brain? It is the microglia. If it goes to the liver, it is the, tell me, if it goes to the liver, the
Puffer
macrophage
cells.
name would be puffer
Puffer
cells.
cells.
Exactly. Exactly. If it goes to the skin, it will be Langerhans cells. If it goes to the placenta, what it is called? Placenta is half
Burners.
bar cells. Half bar cells. If it's to the lymph node, we call it as the histiocyte. If it goes to the spleen, it's called the littoral cell. Littoral cell. If it goes to the kidneys, we call it as the mesangial cell. How about the bones? What is the macrophages that is present in the bone?
Osteoclast.
Exactly, osteoclast. So this is what is regarding the macrophages. Then if you come to the other part, I'll tell you the structure. What is this one? Can you tell me what is this? First, identify what cell is this. A normal cells in a tissue, you can say inside a blood vessel, if it's like this, when monocyte, when it goes to the tissues, it becomes a macrophage, right? Macrophages will be like this. When the macrophage action has to be more nucleus will enter that cell. It will engulf lot of microbes, and hence the power of the cell has to be more. It has to become big enough to fight against its situation. So all the nuclear contents inside the cell will become, inside that macrophage will come to the periphery and form a circle like this, and it looks giant like this, and hence it is called as the giant cells. These giant cells are basically the macrophages. There are different diseases in which these giant cells could be present. This is a giant cell that is present in tuberculosis. And the giant cell, what is the name of the giant cell present in tuberculosis?
Horseshoe
It
shape.
is, no, it's Langerhans giant cell. It is Langerhans giant cell. Look at the peripheries of this cell. Look at this peripheries. This is the giant cell with the nucleus and the nuclear contents in the periphery. And even if you see the nuclear contents inside, there will be the surrounding tissue. It is try to digest the surrounding tissue and go for it and try to solve the problem. That is Langerhans chain cells. What is this cell? I'll give you a hint. This cell is seen in, this giant cell is seen in measles. This giant cell is seen in, exactly, Warthin Spindle cells. Spindle cells. Warthin Spindle cells are pathognomonic of measles. Okay, then this one is very easy. The one with the two eyes. What is this type of sorry?
RSL.
What is the name? Full form. I agree, RS. Reed-Sternberg cell. It's seen in
CMD.
it is seen in Hodgkin's lymphoma.
Hodgkin lymphoma.
It's seen in Hodgkin's lymphoma. Okay. Then what are these cells? These are the Towtown cells. Towtown giant cells that is seen in xanthoma. Okay. Then this one, this area. First to see what tissue is it? You tell me the tissue that's itself enough. What is the tissue in the background? Lot of fibers coming here. Everywhere there are fibers like this. Right? What is the tissue? Sorry?
Cardiac tissue.
Agreed. It's a cardiac tissue. Very good. Super. So, in the cardiac muscle, there is an inflammation that happens. So, what is a possible infection leads to that disease in heart? Rheumatic heart disease. In rheumatic heart disease, there is this big giant cell in the cardiac fibers that is called as the Ashkoff giant cell. Ashkoff's giant cell that is present in the cardiac tissue in rheumatic heart disease. So this is what is regarding the cells. Then coming to the types of immunity that you have, that is one is an innate immunity and the other is the adaptive immunity. What is an innate immunity? Anyone? Is it a natural or an acquired one?
Natural.
It is a natural immunity. Agreed. It is a native immunity that is present inside the body. It is usually this innate immunity is because of repeated exposure to that particular organism in the body that leads to the release of mast cells, polymorphonuclear necrosis, that macrophages, the dendritic cells. All these things will cause the lysis of that particular multicellular organism or the cellular infection. I can say any infection. This innate immunity will protect. What is an adaptive immunity? It is an acquired immunity. Say, for example, you give some vaccination. What will happen? In that vaccine, there will be that antigen will be present in a, in a suppressor state. When that antigen is exposed to the body, this antibody will be produced, and that antibody will produce a memory in the B cells of our body. So this memory will be there throughout our life. So whenever this infection or this particular virus comes inside the body, this memory will be activated and immediately antibodies will be formed so that it destroys the organism as much early as possible. This is an adaptive immunity. Coming to the immunoglobulins. Immunoglobulins are basically released from the plasma cells, right? What are the different types of immunoglobulins that you know of? Immunoglobulin G, immunoglobulin M, immunoglobulin A, immunoglobulin E and immunoglobulin D, right? I'll tell you only the important points. G is the maximum concentration. 80% of the immunoglobulins are IgG. Then it crosses the placenta. It crosses the placenta. And it has got the least carbohydrate content. It has got the least carbohydrate content. And this one is mostly involved in fighting chronic infections by opsonization. Fighting the chronic infection by opsonization. Then immunoglobulin M. What are the points that you know of immunoglobulin M? First, it is a pentamer, right? It is a pentamer. Second thing, it has got the maximum weight because of this pentamer and maximum size. And it is the earliest immunoglobulin to be produced by the fetus. And it is mostly intravascular. It is mostly intravascular. IgA, where else do you see the secretion? IgA will be secreted mainly in the colostrum. Breast milk plays a major role for the child mainly because of this IgA. And it is there in the saliva, there in the tears. It is basically the first defense system that's activated in the body. I mean, the first immunoglobulin to be activated for the particular disease. And it also activates the complement pathway. Okay, then IgE. IgE is the one which has got the least concentration in the body and has got the shortest half-life. Maximum carbohydrate, that is the maximum glucose content will be there in this IgE. And it is the main defense for the parasites. And it is also involved in the anaphylactic reactions. Okay. And it is heat labile. It is heat labile. This immunoglobulin D, it does not have a much role to play. I'll say that it is released from the B lymphocytes. It will be present on the surface of the B lymphocytes. If you ask me the MCQs regarding the immunoglobulins, which immunoglobulin has got the highest half-life? Tell me two things, the highest half-life and lowest half-life. Highest half-life, lowest half-life, answer.
Lowest half-life.
Highest half-life.
Lowest half-life.
Exactly, very good. E. Highest half-life?
M.
It's G. GG. Highest half-life is IgG. Okay. Then I already told you pentamer is
M.
Dimer IgA. IgA is a dimer. Which crosses the placenta?
G, ma'am.
IgG crosses except IgG2. Okay, except IgG2, the remaining crosses the placenta. Maximum antigen valency. That is maximum antigen carrying capacity.
M.
IgM, it has got 5, yeah, 5 big, it's big, right? So it has got a high capacity. Then this TB vaccine is there, right? Sabin and Salk vaccine. Sabin and Salk vaccination production is by main immunoglobulins involved are IgA and IgG. Okay, this is what is regarding the immunoglobulins. Then there are few reactions that happen because of these immunoglobulins. That happens is in case of an exposure to transplanted organs. Because of these immunoglobulins, there happens something called transplant rejection. This transplant rejection can be either a hyperacute rejection, or it could be an acute rejection, or it could be a delayed rejection. In a hyperacute rejection, the problem is it occurs whenever there is a preformed antidonor antibodies that is present in the circulation of the patient. Prior exposures to some alloantigens because of like some blood transfusion. Patient previously exposed to blood transfusion might have some antibodies. So if those patients receive a particular graft, or either a good graft or an ischemic graft from the donor, that time this hyperacute rejection happens. This is because of prior exposure to alloantigen. Acute rejection, this is because of the this happens because of the antibody dependent insult that happens to the graft tissue, and this happens within 30 days after the graft tissue is placed. After 30 days means you can say it as a delayed rejection. Okay, then we saw about the B cells. Then if you see that T cells means T cells always have something called as the CD markers. What is CD markers called? CD markers are cluster of differentiation markers. You have to know few CD markers that are very, very important for us, that helps in it could be a hint to solve the problem. If it's a CD1, what is answer? What is a cell which gives the CD marker? CD1 means come on. CD1, it is from the thymocytes. One, two, three, 4, 5, 7, and 8. Up to this, it is a T cell marker. Okay, if you take this 3 specifically, it is a hand T cell marker. Any idea about the B cell markers that is present in the body?
CD 1920.
B cell markers? Yes? 10, 19, 20, 21, 22, 23. These are the B cell markers. Among this, 19 will be the fan B cell marker. Then few specific things like CD21. CD21 will be Epstein-Barr virus receptor. CD41 would be platelet marker. CD16 and 56 would be the natural killers associated markers. And main thing, CD10 is the Kala antigen. These are the possible CD markers that can be asked in your examination. Then coming to few diseases, there are two diseases that you have to know of. That is mainly because of this leukocyte defects. Whenever there is a leukocyte adhesion deficiency, whenever there is a leukocyte adhesion deficiency, the patient will have recurrent infections in the body. Then neutrophilia, severe mental retardation. Okay, this will be the clinical features of a leukocyte adhesion deficiency. There is something called Chediak-Higashi disease. This Chediak-Higashi disease is mainly because of the defect in the chemical mediators, that is the histamine and the ADP. This is mainly because of the mutation in the LIST gene. Because of this LIST gene mutation, there will be deficiency of not histamine, it's serotonin. Deficiency of serotonin and adenosine phosphate. Adenosine phosphate granules in the platelets. So because of this problem, these patients will have platelet deficiencies also, or platelet problems also. The clinical features of Chediak-Higashi disease includes mental retardation, albinism, recurrent infections, increased bleeding time, nystagmus. All these could be a possible clinical features that can happen with the Chediak-Higashi disease. Clinical points, that's all. Then coming to the hypersensitivity reaction. What are the different types of hypersensitivity reaction that you know of? Hypersensitivity reactions. Am I audible to you people?
Yes, ma'am.
Yes, ma'am.
Okay. Hypersensitivity reaction. How many types are there?
4 types, ma'am.
1, 2, 3, and 4. 1, what is the 1? 1 is mainly because of the inflammation. It is because of the anaphylaxis. Asthma, allergic reactions. Or allergies, asthma, angioedema, atopy, insect bite, seasonal hay fever, drugs. All these things will lead to type 1 hypersensitivity reaction. Type 2 will be antibody mediated, and hence you will have this myasthenia gravis, transfusion reaction, Goodpasture syndrome. What is Goodpasture syndrome? What is Goodpasture syndrome? Antibody formed against the glomerular basement membrane. ITP means idiopathic thrombocytopenic purpura. Then graft versus host disease. Graft hyperacute rejection. This is a type 2 hypersensitivity reaction. Rheumatic fever, RH incompatibility. Okay. Type 3 examples. Serum sickness, SLE, Anoxalian purpura, Arthur's reaction, type 2 lepra reaction, polyarthritis nodosa, all these things will be type 3 hypersensitivity reaction. These are all, anyway, you don't have an option, you have to somehow memorize it. Type 4 will be all granulomatous diseases. Example, granulomatous diseases like the TB, then sarcoidosis, inflammatory bowel disease, this type 1 lepra reaction, very important, type 1 lepra reaction, multiple sclerosis, temporal arthritis, type 1 diabetes, contact dermatitis. All these things are possibilities of, all these things are example of type 4 hypersensitivity reaction. So coming to few diseases that is involved regarding this immunoglobulin, one such disease will be the multiple myeloma. What is the pathology behind multiple myeloma? It's a leukemia, right? Basically, in colloquial terms, you can say it as a plasma cell tumor, where there is too much of immunoglobulins that is present in the body. And hence, because of the too much of immunoglobulins, what protein will come out in the urine? What proteinuria will be seen? Bence-Jones proteinuria will be seen. And if you check the patient's urine electrophoresis, sorry, not urine, serum electrophoresis. Serum electrophoresis, what pattern will be seen? M-band pattern will be seen in serum electrophoresis in multiple myeloma. And the most common cause of death in a multiple myeloma is the infection. In the vertebra, what was the feature of multiple myeloma? You will have something called as the punched out lesions. What is the type of calcification that is seen in multiple myeloma? It is metastatic calcification. Metastatic calcification is the one which is seen in multiple myeloma. Then coming to amyloidosis. Amyloidosis, the main organs affected in amyloidosis are the kidneys. Most common organ affected would be kidney. And it is also not only most common, it is a most severely affected as also kidney. The other organs, it can lead to this liver, it can cause hepatosplenomegaly. Heart, it can lead to arrhythmia or a restrictive cardiomyopathy. In joints, it can lead to a carpal tunnel syndrome. Depending on the level of problem, this can happen. The different types of amyloid proteins are seen in a particular disease. Say, for example, disease like multiple myeloma, the amyloid protein that will be seen will be AL type of amyloid protein will be seen. In case of hemodialysis associated with amyloidosis, the type of protein would be A beta 2M. In case of Alzheimer's, associated amyloidosis, the amyloid protein will be A beta. In case of this systemic senile amyloidosis, the type of protein that will be seen will be ATTR. In case of a medullary carcinoma of thyroid, the amyloid protein will be ACAL. In case of this type 2 diabetes associated amyloidosis, the amyloid will be AIAPP. It is basically the involvement of the islet cells. Islet amyloid polypeptide is the one, is a precursor of this AIAPP. So these are the things which you have to know regarding the amyloidosis. Then coming to the another part of inflammation, immunoglobulins, that is the human leukocyte antigen, HLA classes. There are different HLA classes that are important for us. That is HLA class 1. Whenever there is a problem with HLA class 1, B27 antigen, HLA B27, what is the disease that you expect in this patient? When there is a problem or a mutation in this HLA class B27, you cannot afford to miss this answer at all. Ankylosing spondylitis. Ankylosing spondylitis. Then what else?
Reiter syndrome.
Reiter syndrome, agreed. In the eyes, acute anterior uveitis. Psoriatic arthritis. There are many, I'm just mentioning the important things. Psoriatic arthritis. Just at least try to remember this 4 for HLA B27, which is very, very important. You cannot miss this at all. You should remember it throughout your life. Then HLA B8 is the Graves' disease, myasthenia gravis, all antibody mediated, Addison's disease. HLA B51, Behçet's disease. B47, this congenital adrenal hyperplasia. Congenital adrenal hyperplasia. Then HLA CW6 is psoriasis vulgaris. Psoriasis vulgaris. So this will be the HLA class 1 antigens. That is very, very important for us. Then if you take HLA class 2, in that DR2, multiple sclerosis and Goodpasture syndrome. Many are there. I'm just mentioning you the important things. Multiple sclerosis and Goodpasture syndrome are associated with a mutation of the HLA to DR2. Then DR3, type 1 diabetes. It also is also involved with myasthenia gravis and this Graves' disease. Dermatitis herpetiformis. Then DR4, it is type 1 diabetes along with pemphigus vulgaris. Pemphigus vulgaris is an infection of the dermal layer of skin and also the rheumatoid arthritis. This could be a possible question. Rheumatoid arthritis is DR4 mutation. If it's DR5, it is juvenile arthritis. Then DQ7 mutation, it will lead to bullous pemphigoid. DQ7 will lead to glucose when required, and DQ28 will lead to gluten sensitive enteropathy. Gluten sensitive enteropathy will be seen in the mutation of DQ2N9. So this is what is regarding the inflammation part. Coming to a few points in genetics, see, whenever there is a problem with the genome, say, 23 chromosomes are there. Whenever there is an extra chromosome present or an extra chromosome absent, it is called as a chromosomal. It is called as the, whenever the whole chromosome is involved in the change, then you call it as genome mutation. Okay, whenever there is a problem with the particular chromosome because of some mutation, you call it as chromosomal mutation. For example, when this chromosomal mutation, if you think this protein is a word which is like which gives us the normal, imagine that this particular sequence of peptides will give us the proper protein. When this one single peptide is affected, one single molecule is affected, then it is called as the missense mutation. When when that particular peptide is not complete enough to give that particular protein out, then it is called nonsense mutation, because it is not complete to give us the proper product out of that particular sequence. When there is a deletion of content inside during that the nucleotide formation, you call it as deletion mutation. Whenever there is a reversal, you see ETOR, so PETOR. When there is a reversal of the nucleotide, you call it as an inversion type of mutation. There are different types of mutation that leads to different type of problem. Then you come to the genetic disorders that are common in the human being. Genetic disorders, whenever from first generation, if it compulsory goes to the second generation, that means that it is an autosomal dominant mode of transfer. That is compulsory. If that mutation is there, means 100% it will go to the next generation. If the first generation mutation is there, second generation is a normal generation, and third generation, this mutation is recurring back. That means that it is not following the generation, but still it is there inside the gene in a recessive way. That is an autosomal recessive way of inheritance. When a female is having a disease, and if this female is transmitting the disease to the females of the next generation, second generation, compulsory, or even if a male or a female, see, it is male or female. In case of if the child is a female, XX, right? So one from mother, one X will come, father one X will come. Both is X are there. If any one of them have the disease, and if the female in the second generation has that disease, that goes on to say that this is an X-linked dominant disease. Whereas, for example, say a female is having a disease and it goes to the next generation, and the second generation is a female, and this female has normal, and next generation, the third generation, if it's a male, the defective X will come, right? Say this is a defective X and this is a normal X. To this female, this norm, even if the defective X has come from the father, a normal X would have come for this female. So hence she has become normal. Whereas when this female gives birth to a male, the only X chromosome will be from the female. So there will be a small X, and since it's a male, the father will give a Y chromosome only. In this case, what will happen? The disease will get reflected in the disease will be there for the patient. This way of inheritance will be X-linked recessive way of inheritance. That means that if there is a dominant X, means there is no disease. When there is no dominant X at all, only one X, that is the defective X, is there. Only that time the disease was there for that particular child, means it is an X-linked recessive way of inheritance. So we will solve the pedigree chart during the pediatric classes. During that time, we will solve some pedigree chart. This is a rough idea about how the transference happens. So if you see the autosomal dominant diseases, there is no other choice. You have to remember it. I have took some mnemonic from the Google. So whenever you read it, you will be able to at least guess which is an autosomal dominant disorder. I usually remember this osteogenesis imperfecta. It is most commonly asked. And this Marfan syndrome, neurofibromatosis, achondroplastosis, polycystic kidney disease, then hereditary spherocytosis, Huntington's disease. I usually remember this disease and along with this von Willebrand's disease and von Willebrand dust. These diseases all you cannot afford to forget that it is an autosomal dominant way of transmission. Coming to the autosomal recessive way, you always remember all the disorders that you learned in biochemistry, chemical disorders, the one which you learn in biochemistry chapters, right? Those will be mostly autosomal recessive disorder. Okay, alkaptonuria, then this Gaucher's disease, galactosemia, homocystinuria, hemochromatosis, that is a different thing. Okay, all these things will come under inborn errors of metabolism. This is the one which you mostly learn in biochemistry, the disorders. The inborn errors of metabolism will be most commonly an autosomal recessive. Apart from this, you have to know this cystic fibrosis, beta thalassemia, albinism, and Friedreich's ataxia. If you know this, you will be able to guess the autosomal recessive ones. Then X-linked recessive, X-linked dominant ones is very easy. Remember it as Rabi, Rett syndrome, Alport syndrome, vitamin D resistant rickets, and incontinentia pigmenti. Okay, try to remember this. X-linked recessive disorder, usually I remember as Lady Hardin. College girls don't care about the foolish words. Leishman syndrome, hemophilia A and B, Hunter's disease, colors blindness, G6PD deficiency, Jukins muscular dystrophy. We read about this chronic granulomatous disease, right? NADPH deficiency. That is an X-linked recessive disorder, A-gamma globulinemia, Fabry's disease of Fragile X syndrome, and Biscott-Aldrich syndrome. Biscott-Aldrich syndrome will have small platelets. Tiny platelets will be there for Biscott-Aldrich syndrome. So somehow you find out a way to remember this X-linked recessive disorders, because only then you will be able to rule out the MCQs that comes to you. Then coming to the syndromes that are mostly associated with the genetic mutation. One such syndrome would be Turner's syndrome and Klinefelter syndrome. In case of Turner syndrome, what is the genetic defect? Here there will be 45XO. One X will not be present. In these patients, there will be primary amenorrhea. That will lead to infertility. Primary amenorrhea will be there, thereby leading to pneumonia. Then widely spaced nipple will be there for such patients. And of course, the short stature in the picture depicts it. Streaky ovaries. This is a very, very important hint. They will give you on a big question. They'll write streaky ovary. That's all. The answer is over. The simple answers will come out. Streaky ovaries will come only in case of Turner syndrome. And this patient will have short fourth metacarpal. And the cardiac defect that is present in this patient will be coarctation of aorta along with the webbing of neck. So these are the hints that you have to know. Webbing of neck, coarctation of aorta, primary ammonia, streaky ovary. If you get this important hint words, then the answer is Turner syndrome. In case of Klinefelter syndrome, what will be the genetic pattern? It will be 47 XXY. There will be an extra chromosome, 47 XXY. These patients, it is the most common sex chromosomal disorder. First important thing is small testes, hypogonadism. I remember once what happened, there was a guy who came to us with femur fracture. He was looking obese. At the same time, he had a gynecomastia. So we positioned them for surgery. During that time, we gave him a spinal anesthesia. So then while positioning the patient, we noticed that he has got microgonads, hypogonads. The testis was very, very small, not up to the age. After that, we suggested for an endocrinologist opinion. And later, that guy was diagnosed of Klinefelter syndrome. Okay. So Klinefelter syndrome, they look so much normal. I mean, normal in the sense, abnormal when you compare to others, but the height and all those things will be normal. The only differentiation that you see will be hypogonadism and breast development, gynecomastia. This will be the differentiating patient. The thing is that these patients, they will not even know that the gonad size has to increase after a particular age. They will think that this is how the gonads will be for every person. So they won't take effort to check themselves. So for a long time, unless they find it out at one point of time, they will not even know that they are abnormal. And because of this hypogonadism, there will be a decreased inhibin and testosterone for these patients. And increased FSH and LH. These patients are highly prone for a germ cell carcinoma of testis. They are highly prone for a germ cell carcinoma of testis. These are the important points regarding Turner's and Klinefelters. Fragile X syndrome, it is basically because of the brittle chromosome, and hence the name Fragile X syndrome. These patients, in the opposite, they have a large testis. It's an opposite to Klinefelters. They have a large testis, and the defect, chemical defect here is the triple nucleotide repeat defect. Triple nucleotide repeat defect. This is the problem, and the nucleotide that is repeated is the CCG. And these patients will have a broad forehead with an elongated face with a prominent big ears, sometimes with strabismus and a high arched palate. So if this patient comes to me, I will be like, high arched palate. This patient is a very risky patient for a chances of difficult intubation could be there for this patient. So I as an anesthetist, that will be going on in my mind if I see such a patient with a Fragile X syndrome. Okay, this is what is Fragile. Then the common, what is the syndrome? Tell me.
Down syndrome.
Down syndrome.
Exactly, Down syndrome. What is the pathology behind Down syndrome? It is
Trisomy 21.
trisomy 21. It is the most common chromosomal disorder. And trisomy 21, these patients will have this wide spaced eyes. They have an open mouth always. Epicanthal folds will be there, and this neck will be there. And in the ultrasound, in the 3-month ultrasound, what will be the problem? What will they check in the 3-month ultrasound to rule out Down syndrome?
Neutral thickness.
Exactly, nuchal thickness. Nuchal thickness is what they see in the ultrasound. So, and these child have cardiac defects. What is the most common cardiac defect that is present in this such a child? Okay, what is the most common malignancy that is present in the Down syndrome patients?
The cardiac
Malignancy
is it tetralogy the cardiac
Down
cardiac defect?
syndrome? No.
Endocardial cushion defect.
Sorry?
Endocardial
They
cushion
will have
defect.
exactly endocardial cushion defect. Endocardial cushion defect. This endocardial cushion defect is the one which is the quadrant. Rather, I will say this endocardial cushion defect is the one which leads to the atrioventricular septal defect. So this is the most common cardiac defect that is present in the Down syndrome. The most common malignancy is AML. AML is the most common malignancy, and these patients are highly prone for Alzheimer's disease. High chance of Alzheimer's disease are there for this Down syndrome children. Then what else? These are the basic things that you have to know. Then I'll tell you the trisomy. You tell me the name of that particular thing. Trisomy 13. Trisomy 13. What is the name of this trisomy 13?
Pathology syndrome.
Pathology syndrome, exactly. Pathology syndrome, what are the clinical features of Pathology syndrome? One feature you tell me, that is enough. That is
The
very
flat and
important.
boat like feet, ma'am. Feet வளர்ந்திருக்கும்.
Okay, then
Left
lip.
polydactyly, then cleft lip, and holoprosencephaly. Okay. Then what is trisomy 18? What is trisomy 18?
Edward syndrome.
18 is 18, right? So E, Edward syndrome. Feature of Edward syndrome? They'll have microxanthia. Small eyes, microxanthia will be there, and overlapping of flexed fingers. Flexed fingers will be overlapping on each other. That will be seen with trisomy 18. Then this trisomy 8, Trisomy 8. Sorry, I've written 18. I'm sorry, it's 8. Trisomy 8, what is the disorder? It is called as the Varkany syndrome. It is called as the Varkany syndrome. There are high possibility of miscarriage to happen. Here, short stature, mental retardation, and retarded psychomotor development. Retarded psychomotor development. This will be seen with Varkany syndrome. Then, we know about the mitochondrial disorders. Any idea about the mitochondrial disorders that happens because of chromosome 15? In chromosomal 15, there will be genomic imprinting, right? When there is a problem with this chromosome 15 genomic imprinting, the mother and the father both will give, right? If there is a maternal deletion or a paternal addition in this, what will be the disease that comes out? Or the reverse, in the maternal, if there is an addition, if it is a paternal deletion, what will be the disease? Come on. Yes. Can you hear me?
Angelman syndrome.
Angelman syndrome. How will you remember it? See, angel is the mother, right? Man is a father. The father has become an angel now. The mother has gone and father has become an angel now. And that's how you remember it as Angelman. Paternal addition is an Angelman syndrome. How about maternal addition or a paternal deletion? It is
Prader-Willi syndrome.
Prader-Willi syndrome. Prader-Willi syndrome. What will be the clinical features of this patient? These patients, mostly both will be in the autism spectrum range. Autism spectrum disorder, both will be in the autism spectrum where I will say, and Angelman syndrome and more of an autism spectrum disorder, and this Prader will be psychotic spectrum disorder. This patient's Angelman will be hyperactive and they'll be sleepless. Whereas this Prader-Willi will be always sleepy, very inactive. Okay, these are the main differentiating feature that you have to know of. And this Angelman is called as the happy puppet. Happy puppet syndrome. Okay, this is what is regarding the chromosomal defects. Then coming to few other chromosomal involvements. There are many, and I don't know whether you'll be able to remember everything. I'll tell you the most important things. Chromosome number 1, whenever there is a defect, what is the disease most commonly seen? Neuroblastoma. Chromosome number 2, cystinuria. Chromosome number 3, renal cell carcinoma and von Hippel-Lindau disease. Chromosome 4, it is Huntington's chorea. Then chromosome 5, Cre-du-Chat syndrome, or the familial adenomatous polyposis. Right? Chromosome 6 is hemochromatosis. Chromosome 8, osteopetrosis. Chromosome 9 is Friedreich's ataxia and tuberous sclerosis. Friedreich's ataxia. Chromosome 11 will be the Wilms tumor, the most common solid tumor in a childhood. Then MEN1 will also be multiple endocrine neoplasia 1 syndrome, will also be chromosome 1 defect. Very important. Chromosome 13 is retinoblastoma, will be because of this. And Pato syndrome we already discussed. Then Wilson's disease, because of the copper metabolism deficiency, you have the deposits of copper in the liver. So Wilson's disease because of 13. 15 we already saw. 16 is the polycystic, autosomal dominant polycystic kidney disease. Then 17 will be neurofibromatosis. How do you remember this? Neurofibromatosis. If you count this, 17 will come. Neurofibromatosis 1, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. See, I told you 17 will come. Neurofibromatosis spelling 17 will come, so 17 chromosome. Then also P53 will also be chromosome 17 involved. 18, 21 we already saw. Chromosome 22 is important because chromosome 22 is involved in neurofibromatosis 2. That is one thing. Second thing, 22q11, if there is a deletion, that mutation will lead to Dijot syndrome. Dijot syndrome, they will not have thymus at all. So basically, these patients will not have the basic immune power from the T cells. Thymus will not be present in the childhood. So recurrent infections will be there in this Dijot syndrome. Then that's all much, not much. I've always covered all the chromosomes. So nothing much to say. Then coming to few tumor suppressor genes. Whenever there is a mutation of a particular gene, there will be particular particular carcinoma that develops. Whenever there is a mutation of KRAS, what will be the disease that forms KRAS mutation? KRAS mutation will lead to colon cancer, pancreatic cancer, and lung cancer. NRAS mutation, it will lead to AML, melanoma. HRAS mutation, it leads to bladder carcinoma and kidney cancer. c-Myc mutation will lead to Burkitt's lymphoma. Very important, c-Myc, Burkitt's lymphoma. N-Myc, neuroblastoma. L-Myc, it will lead to small cell lung cancer. RET gene mutation, it will lead to the MEN2 syndromes. Then ABL, CBR-ABL. Sorry. That gene mutation, it will lead to CML, chronic myeloid leukemia. Retinoblastoma, of course, you know that just retinoblastoma or osteoblastoma. Neurofibromatosis, you know, this WT1 will be Wilmstoma. BRCA1, female breast cancer, whereas BRCA2 in the male breast cancer. Gynecomastia terlava carcinoma. That will be the genes and the associated tumors. If you see this, there is a syndrome, when you speak about this Wilms syndrome, I remember Wilms tumor, I remember a syndrome which is called as Vaggard syndrome. Wilms tumor, then aniridia, genital tract anomaly, and retarded babies. This will be the features of Vaggard syndrome. Then coming to few paraneoplastic syndromes. What is a paraneoplastic syndrome? Primarily, there is one carcinoma. That carcinoma is releasing some substance inside the circulation, and that substance in turn is causing syndrome or some problem inside the body. Say, for example, bronchogenic carcinoma, it releases antibodies inside the body that go and acts at the level of acetylcholine receptors. Thereby, it causes the paraneoplastic syndrome of myasthenia gravis. In case of an oat cell carcinoma of lung, oat cell lung cancer, pancreatic cancer, and gastric cancer, there will be release of steroids inside the body, thereby leading to Cushing's syndrome. Then bronchial adenoma. And pancreatic cancers or gastric cancer, they release, what do they release? They release serotonin inside the body, okay, thereby causing carcinoid syndrome. How do you diagnose carcinoid syndrome? Carcinoid syndrome is diagnosed by measuring 24 hours urine 5-hydroxyindole acetic acid. This is a precursor of the serotonin. So 5-hydroxyindole acetic acid 24 hours measurement will give us an idea about the carcinoid syndrome. Then coming to the small cell carcinoma of lung. This is a very important question you must be knowing. Small cell carcinoma of lung. What will it be? It will cause hypercalcemia. So hypercalcemia leading to the calcifications in the body. So metastatic calcification in the body. Even breast cancer, renal cell carcinoma, adult T cell leukemia, ovarian carcinoma. All these things leads to hypercalcemia. Then coming to hypocalcemia, it is caused by fibrosarcoma, mesangial sarcomas, and hepatocellular sarcoma. Hepatocellular carcinoma, this leads to frequent hypoglycemia. Then renal cell carcinoma, cerebellar hemangioma. Cerebellar hemangioma, hepatocellular carcinoma. This leads to the thickening of the blood. So remember it as polycythemia vera. Polycythemia vera, it will cause thickening of the blood. Then gastric CA, lung carcinoma, and uterine carcinoma. This will lead to acanthosis nigrans. Acanthosis nigrans. Acanthosis nigrans is dark color pigmentation around the neck. Then bronchial. So bronchogenic carcinoma has so many paraneoplastic syndromes. The bronchogenic CA and breast cancer has a lot of things. One among that could be dermatomyositis. Intracranial neoplasms can lead to SADH, severe inappropriate antidiuretic hormone. Then last but not the least, which is to be remembered as the pancreatic cancer, along with the bronchogenic cancer or separately. This can lead to Troushius phenomenon, whereas there is a chances of frequent venous thrombosis to happen. So these patients will highly precipitate deep vein thrombosis. So we have to always anticoagulate these patients with pancreatic cancer. So this is what is regarding the carcinomas. We'll take a 5 minutes break and then we'll go. Am I audible? Am I audible?
Yes, ma'am.
Is my screen visible?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Okay, perfect. So in GIT, we saw the narrowest part would be the grippopharyngeal constriction. And this constriction, it will be at the level from the incisor teeth, it will be around 15 centimeters from the incisor. The grippopharyngeal constrictor. And the next constrictor would be at the level of the aortic arch, which would be around 22.5 centimeters from the incisor. The next would be at the level of the left bronchus, which would be 27.5 from the incisor. And next at the diaphragm level, which would be around 40 centimeters from the incisor. In the esophagus, the most important thing that you have to know is regarding the esophageal carcinoma. So you tell me, in the esophagus, which is the most common carcinoma in the upper part? Most common carcinoma in the upper part would be squamous cell carcinoma. The one in the middle part is also squamous cell carcinoma. The one in the lower part would be adenocarcinoma. Okay, this is very, very important.